Hello, everybody. Thank you for your patience. We're just waiting for everybody to be able to get online and join us today. So we can get started with our fifth session, which I'm delighted to open. As most of you now know, but I will give you a little recap anyway. ISUP is the International Society for Substance Use Professionals, a membership organisation that's focused on the development, support and representation of a professional workforce in the substance use prevention, treatment and recovery field. We address our mission through sharing the latest evidence-based ethical quality information and by really promoting those opportunities for continual professional development, keeping in touch with information and connection with each other, both nationally and internationally. Unfortunately, as a global organisation, our members are separated by distance. So therefore, one of our key channels is the digital, the online presence. We use it to facilitate connection and professionalisation. We do this with our website, with our newsletter, our social media channels, and we also work on the ground in a more local context via our national chapters, who've been really able to deliver our mission within their countries to meet the needs of the members within those countries. We're delighted that events like this are now able to go online. We used to do them face-to-face, but this platform really allows us to keep up that connection, but also increase our reach. So as I said, this is now session 5. We're delighted to be holding this in collaboration with our partners, and everybody has really worked very hard for this series of events. We've been working with ISUP South Africa, the African Union, South African National Council on Alcohol and Drug Dependence, the Department of Social Development of the Republic of South Africa, the Organization of American States, and of course the US Department of State's Bureau of International Narcotics and Law Enforcement Affairs. So thank you to all of you for playing your role. Some housekeeping for today's session. As always, there are interpretations taking place, and you should be able to see in the chat box that information on how to connect to those live interpretations. All the questions we will be gathering and putting to our speakers at the end of the session. So again, please pop those in the questions in the chat box and we will gather those up together. Please bear with us if there are any technical difficulties. We are, of course, all doing this from different places around the world. So we are hoping that everything runs smoothly, but bear with us if there are the odd connection issues. The ISUP network is going to be happening and people can chat to the other participants during the session. And also just to note that this recording and all of the presentations will be available after the event. So all of the information that you're seeing, you'll be able to get to afterwards. So starting with the session, today's plenary is focused on the role of legislators and traditional health practitioners in drug demand reduction, and we have the pleasure of having our first part of the session moderated by the Honourable Hendrietta Bogopane-Zulu, the Deputy Minister for the Republic of South Africa within the Department of Social Development. So I'll be handing over to you now for the first part of the session. Thank you very much, Deputy Minister.
Thank you very much, Joanne. Thank you very much, everyone. And thank you for joining us this afternoon. Let's greet everyone around the world and still say South Africa still stands, and we're here. We're very happy to actually get this agenda going. We know that as legislators, I think I've been South Africa's youngest legislator. So 27 years of democracy, and one was there. I think I was 22 when I became a member of parliament, and I'm still there many, many years ago. So it's very important that we understand the role that parliaments, legislatures, senators, in whatever form that called the power that we have as those that make the laws. And I hope this session, welcome all the speakers, and thank you, honorable members, for making yourselves available and giving us your time. We really appreciate it. But we also want to say wala to all our traditional healers that have connected. We're excited as in particular Africans to actually create the space, and we're looking up to all of you as legislators to ensure that the important role that traditional leaders play will always be and traditional healers play in our lives and in the drug agenda. So for the first speaker, talking about, let's remind all of us, the role of legislatures in drug demand reduction. The laws we make in the drug world, they've actually been very harmful. But let's take our first speaker who will take us on a journey and talk to us around what is it that needs to happen. And that is Senator Mattie Hunter, Illinois State. And we would like to say, where are we, what are the laws, and what is actually making us not do that is required, and what are we going to do about it? And she is from the senator from the Majority Caucus chair. Wow, my party back home here as well. The 3rd Legislative District, the United States of America. Senator, you have the floor.
Hello, everyone, and thank you very much. Deputy Minister Zulu. While the world is experiencing an unprecedented COVID-19 pandemic, I give my condolences to those who may have lost a loved one or who may know someone who may have tested positive. My colleagues and I have been busy facilitating 5 to 7 virtual meetings such as this daily, working with alcohol and drug community-based providers, community and faith-based leaders, and governmental leaders who are advocating for more funding to purchase face masks, gloves, and food for our clients. This has been a great example of how community advocates interact with government. Since 1981, my commitment and work in the addiction field has been a rewarding experience. Starting with as a university student, then I became a clinician in the field, community leader, manager, administrator, and now since 2003, a legislator. In 1994, my then employer, Human Resources Development Institute, better known as HRDI here in Chicago, were approached by the US State Department International Narcotic Law Enforcement to travel to South Africa to train Black social workers in Joburg, which started a very strong and lasting relationship with National Sanka and the Center for Health and Human Services, which was an NGO that we formed once we were on ground over in South Africa. That partnership brought us back together again in Cape Town in 2009 for training, as well as in Durban in 2012, focusing mostly on demand reduction, prevention, and advocacy. And so when we're talking about good policy is a collaborative effort between elected officials and various advocacy groups. The Illinois General Assembly, every year we pass at least, or we consider at least over 1,000 pieces of legislation annually with regular constant considerations to impact advocacy groups and individuals. You can move the slide, please. In terms of disagreeing or helping us structure policy. And so none of those pieces of legislation are acted upon until we hear from various types of advocacy groups, letting us know that they support it, they do not support it, what is it that we need to change, and so forth and so on. Move forward. In terms of my career background, I have a bachelor's and a master's. I'm a certified alcohol and prevention specialist since 1985. I've worked in the field since 1982, and I've been all over the place working and advocating for the better good of the people. So what is advocacy? I know that you all are wondering exactly what is advocacy moving forward and why do we need advocacy? Well, here's a definition of advocacy. It's the act of pleading or arguing in favor of something, such as a cause you may have, an ideal, or a policy. And what we need to do and how it works is to protect the rights or to change a discriminatory or an abusive treatment to fair, equal, and humane treatment. It could also remove Advocacy could also remove barriers which prevent full access or full participation in community life. It'll also assist you in bringing you to the table with decision makers to help us make decisions as decision makers, because we do not have all of the answers. But the advocates, the community people, the faith community, they know most of the time better what the issues are than we, because they're on the ground and they're working it with it. Let's move forward. So while you're advocating, some people, they think that they should demand all the time. There's no need to demand anything, in my opinion. Do not be pushy. When you see, when a legislator allows you an audience with them, just be cool, calm, and collective. There's no need for any personal attacks or question a legislator's integrity. Do not play one legislator against another. And the reason why you should not do this is because we talk to one another and we compare our notes. And so we know who we're working with and who we're not working with. Always keep that legislator informed and be truthful. It's always good to be honest and truthful, and also be patient, because you're not going to change the world today or tomorrow. It takes time. I know every piece of legislation that I've passed it takes sometimes 3 to 5 years or sometimes more to pass that legislation. So be patient all the time. Let's move forward. So who needs to hear your message that you would like to advocate on? Elected officials, first of all, because we're the ones that will stick our neck out, support you, and help you pass that legislation. You need to also work with key stakeholders, whomever those key stakeholders could be, persons that you're working with already in the field. Key agency administrators. These are the department heads, the Department of Public Health, the Department of Alcohol and Substance Use. Those are the key administrators that you must work with, so that you may get an audience with them, so that they may hear your message. Also, let's not forget grassroots. And when I say grassroots, I'm talking about the faith community. I do not work on any kind of legislation unless I have the faith community right there with me, not only to pray with me, but to simply work with me, because many of them are on the ground. And we also include our community leaders. We also include our junior colleges. Universities are important as well, because we receive lots of data from universities, but the junior colleges are most of the time located right there in the community. They know many of the community leaders and all of the other grassroots people. So therefore, it's always good to include those categories. And if you can bring more categories to the table, the more the better. Let's move on. And so an example of using effective advocacy is that the Senate Bill 2951, in which I was a co-sponsor. So we worked with one of our department heads and departments to develop a pilot program, meaning that it only lasted 2 to 3 years, to treat youth. Many of our youth are using drugs and young adults. And we as legislators had to intervene on their behalf so that they will not kill themselves. So therefore, we got together with our advocates and other youth and young adults to put together a program. We also had to find the funding, but that's how we were able to get that piece of legislation done. Another piece of legislation was Senate Bill 1828. Let's move on. I was also the co-founder of that, the co-sponsor of that piece of legislation as well. And so what happens is that this bill requires information on substance use treatment and the capacity. And also an annual report had to be produced regarding the overdose trends. We're having a huge problem over here in the US, particularly in Illinois, as it relates to opioids and overdoses. So therefore, we had to create and disseminate information to our grassroots organizations so that they can go out into the community to educate community leaders, common people on the do's and don'ts of overdose, okay? And we had to also produce an annual report to make sure that the word got out. And the details on how local governments, local Department of Human Services, which operated these particular programs to support our drug overdose prevention, recognition, and response projects. And so you must work with folks on a regular basis in order to get your word out. And we also need the monies to fund these initiatives. So therefore, you bring all key stakeholders to the table. And so another slide, please. For our upcoming next year, fiscal year, since the opioid use is extremely high now, we had to find funding for prevention and recovery. And so we were very, very successful for the upcoming fiscal year 21, which starts in January, to pass. And we were able to secure a whopping $86 additional million to address this issue regarding prevention and treatment. So in terms of breaking it down, 63 million went towards substance use treatment. $1.1 million went towards substance use prevention. Now, many bodies of government do not invest, particularly over here in the US and in Illinois. We only spend historically a fraction of 1% on prevention. And we've been advocating as legislators, especially myself, that 1%, a fraction of 1% for prevention is simply not enough. We need more monies for education and dissemination of education. So we came up with this time $1.1 million. I'm not satisfied with that amount, but it's a start as far as I'm concerned. You see, sometimes you can't get everything you want when you're advocating for more programs and services and dollars. And so therefore, you take what you can get for that moment and you go back the next year and the following years until finally you get the entire package in which you need to get the job done. And also $12 million went to substance use prevention and treatment providers. We put the money in the field, on the ground, to all of the different agencies, the grassroots agencies that provide the substance abuse treatment and prevention, so that they can easily access those persons in those particular neighborhoods who are inflicted more. And so also, as a result of COVID, we were able to identify $30 million in new emergency funding for mental health, substance use, and other counseling services. So mental health, I did not speak very much about mental health, but as a result of people having to remain in their homes, having to wear masks, you can't congregate with many people. Folks are having some serious mental problems. They're stressed out. And so we were able to appropriate $30 million to work with people who are in need of these services. We've also seen a huge increase in suicide. And so those $30 million would go towards that. Also in rural areas, we've instituted something that we call telehealth, where you cannot get in to see a doctor or your therapist. So therefore, you can use a telehealth on your phone, where you can talk to your counselor, you can talk to a therapist, you can talk to a healthcare professional to address your issues. Many physicians are also using it for medical problems as well, which has been working extremely well, because people are feeling boxed in at this particular time. And it's time for us to give them some sort of relief. And so many people cannot get in to make home visits and office visits. And although you have some therapists who are actually going into the home, but because of COVID, it's taken a big risk in terms of going into a person's home. So at this time, I am going to conclude my my presentation. My last sheet on my presentation shows my contact information. I have a website on here, my email address is on here, my phone number. And so if you need some additional information or would like to talk to me, this is how you reach me. Thank you very much.
Thank you very much, Honorable Hunter, and thank you so much for the work that you do. But above all, thank you for reminding us, I was looking at your profile, that women remain amongst those that we really need to reach in the different programs that we do. Without any waste of time, I would like to then introduce our second presenter, Senator Honorable Honorable Seth Kwame Acheampong. I really practiced. And he is the Member of Parliament from Ghana, and he is the current chair, which I think I like, the current chair of the Defense and Interior Committee. And I think you're gonna make us understand how you in Ghana are actually doing this. And there's a lot of lessons we are learning from South Africa, for South Africa from Ghana, because you've really made the necessary moves. So over to you, Honorable Member. You have 15 minutes.
Thank you very much. Thank you. Hello, good afternoon, everybody. It's South Africa is 2 hours ahead of Ghana, and we are here right now. And my presentation is structured on our new law, that is the National Narcotics Commission, which we have done, and that is on illicit drug. And Ghana, as we all know, and first and foremost, let me say I'm grateful and thankful to our moderator for your kind words. As a chairperson for Ghana's Select Committee on Defense and Interior, our responsibility is to oversight the executive in the agencies of defense forces, homeland forces, and intelligence agencies of state. And in Ghana's architecture, homeland is in control of drug management. And so it falls within our purview to work hand in hand with people in homeland. And that's why we have this presentation. And so by my invitation, I thank the organizers for the opportunity first and foremost. And I'll move on straight into my slides. So if you may share my slides on the introduction. I just would want to state that Ghana is a signatory to the United Nations Convention on illicit traffic in narcotic drugs and psychotropic substances. That's the 1988, which came into force on the 20th of December 1988. Ghana demonstrated the convention in 1990, and then we made a PNDC Law 236. However, the PNDC Law 236 was more on illicit dealings in narcotic drugs, and its Section 55 established the Narcotics Control Board, the oversighting and managing body for narcotic drugs and psychotropic substances in Ghana. It is significant to mention that apart from the PNDC Law 236, Ghana has enacted major laws that have an impact on the process of serious offenses. And these include, if you may move the slide so that people would follow my narrative. I think I'm done with the first slide. I plead with you to share further slide. Thank you very much. And the focus has been, Ghana's outset was primarily on prohibition and how we could reduce demand reduction in our neighborhoods. And this was through making sure that their trade is well looked into. And so Ghana enacted the Anti-Money Laundering Act in 2008, and then we went further to do the Anti-Money Laundering Regulations in 2011, LI 1987, and then the Economic and Organized Crime Office Act in 2010, Act 804, as well as the Mutual Legal Assistance. You may continue with the slide, please. All these laws were put together for better management. In spite of these very significant enactments that have a bearing on drug control, it's be necessary for Ghana to ensure that the country's narcotic legislation meets the African Union plan or African Union action plan on action on drug control, as well as the current international standard for drug control, which has now shifted from just prosecution of persons found to have committed narcotic drug offenses to also focus more on drug demand reduction. And so PNDC Law 236 has been repealed by the current Narcotics Control Commission Act 2020, Act 1019. May we follow the slide again? I would want to share some highlights of the legislative changes regarding to drug demand reduction in Ghana. Scope is the legislative changes on drug control. So you may go again. The aim was this, then the legislative changes on drug control. And I want to state that the Act 1019, please, you may go again, legislative changes on drug control. Act 1019 was passed in this year, March 2020, and subsequently assented to by the President of the Republic of Ghana in May, and is now established the Narcotics Control Commission from the board which was managing it in the time past. The commission has been trying to address the weaknesses that we saw in Law 236, which our constitution in our Fourth Republic allows. The objects of the commission, fully established now, is to ensure public health and safety. These are very crucial for me, by controlling, preventing, and eliminating traffic in prohibited narcotic drugs and plants, and by taking measures to prevent the illicit use of precursors, and then developing measures for the treatment and rehabilitation of persons suffering from substance use disorders, and then developing alternative means of livelihood for persons who cultivate narcotic plants, and facilitate the confiscation of proceeds from narcotic-related offenses because of the nature of the drug trade. And we trying to help give alternative livelihood and development. We in this law have created opportunities for those who indulge in this practice to have alternative ways of livelihood. And at the same time, those who suffer under substance use disorders, making it a public health matter so that they will fall in the mainstream of public health management. These are some of the newness we brought into the new law. May we follow the slide? The act is to ensure public safety by controlling and eliminating traffic in prohibited narcotic drugs and also taking measures to prevent the illicit use of precursors. In Ghana, one of the challenges are that the pharmaceuticals also use precursors, and more often than not, they fall in dangerous hands, and these get into the drug market, and substance use in that order get more arising, and it is affecting the management of the menace in Ghana. Let me go on the next slide, please. This act, like I said earlier, has offered the Commission to develop measures for treatment and rehabilitation of persons suffering from substance use disorders. This was not in the earlier law, and so we did not know of this. So in this new way, we are making it more a frontal conversation within the public health management associations and institutions and public bodies that are mandated to help us mitigate public issues. We go on with the next slide. The Act also provides for a trust fund for the rehabilitation of persons suffering from substance use disorders. So we are making sure there is also some mitigation support social services, and then at the same time investing in reform institutions so that people who have fallen victim of alcoholism, drug abuse, and any form of substance use disorder may enjoy the benefit of treatment and at the same time a rehabilitation through the processes, which was not the case in the earlier law. And so by this, the legislature has enhanced the management and the treatment of drugs in Ghana. The Act also, I would want to see the next slide, please. The Act also mandates the Commission to develop, in consultation with other public agencies, which I've just said earlier on, and civil society organizations, an alternative means of livelihood for farmers who cultivate illicit narcotic plants, because we need to ensure that the farmers will not go hungry and they don't have anything doing, so that they would be encouraged to cultivate these substances, because the new law makes provision for cultivating cannabis, which is of a 0.3% dry weight, for medicinal and industrial purposes. And this is one of the measures that the new law seeks to enhance industrial development by virtue of the policy in alternative development. And these are some of the things that we seek to do. The Act also mandates the Commission, in consultation with, I've said this already, maybe yes, the funds of the Commission will be approved by Parliament. We would want the reps of the people to have total control over that, and it should not be by any other individual's interest. Legislative members would need to have a thorough look into it, peruse it, scrutinize it, and then grant same to members of the Commission. And at the same time, it will welcome grants and gifts and donations where necessary, and it does not offend any existing enactment, so we do not fall under any of such challenges. Next slide, please. It is also worth to mention that Ghana is a member of the Epidemiology Network on Drug Use and Epidemiology on Drug Use in West Africa, where harmonization on drug use is being put together in the West African sub-region and the African continent as a whole. And so this is part of the regional understanding that we are gathering and ensuring that what we have gained in knowledge we share with our neighborhood, and then we also incorporate the best practice from other regions within our sub-region, so we can be abreast with best practice in society now. May we receive the next slide, please. We would want to also encourage research development. And so we're going to research into the area of addiction disease and then treatment of persons. So we give scientists some better, deeper, as a developing society and a country, most of our scientists would have to also up their appreciation of the subject, social sciences as well as physical sciences. And so the prevention and setting up of rehabilitation centers and capacity building for professionals in addiction treatment, because in the times past, they've just been kept in rehabs at asylum centers where we have only those who are sometimes hard drug users. And it's instead of helping reform people, we rather, unfortunately for what used to happen in the past, mess them up, if I may allow to use so, because they become more hardened and it does not help us. Some would have to unnecessarily be incarcerated. There were no measures. People with substance use for possession for little use were just incarcerated for not being considered as people with disorders. They were just seen as offenders and criminals. And this new act is seeking to change and bring a new dimension in the management of the drug issue in Ghana. The act also mandated a commission on the authority. The next slide, please. The act also mandated a commission and authorized the Attorney General to prosecute all narcotic-related cases in court. Hitherto, in Ghana, all state prosecutions are effected by the Attorney General of the Executive. We have sought to allow practitioners in the new commission to handle these cases because handling and managing them and living daily with them has given them more insight. And so they will bring more human-centered and more human face into the management of such persons. So they do not just go and apply the rules and the laws that we have enacted from the House capriciously. They would go and follow through on case-by-case specifics so that no one is shortchanged. The next slide, please. For enhancing our drug management, we're going to establish a better forensic laboratory for testing, analysis, and storage, and for destruction of any narcotic drug, precursor equipment in relation to the investigation of offenses and court proceedings. So these are part of broadening the management scope in the Ghanaian perspective. Thank you. May we go on the next slide. In conclusion, I must say that Ghana is very committed to legislate effective drug control policies in line with international standards to curb the drug menace. In what the UNODC has done, and in what the UNGAs have done, and what African Union Action Plan is telling us, and West Africa is telling us, Ghana is in the forefront to ensure that most of these international treaties and conventions that we are already signed on to are further domesticated and made more reasonable and more open and closer to a human-centered security management. With this in the fore, we believe that it will enable drug enforcement, drug management, drug treatment, harm reduction measures that is already in the fore that is being done. Yet to be done by this parliament is the regulation to enhance the cultivation of cannabis at the 0.3% tetrahydrocannabinol content, which is not the global and appreciated level of substance use for industrial and medicinal purposes, to obtain our CBDs, to obtain fiber for industrial purposes. This is what Ghana is getting into, and Ghana is well prepared to partner any other person interested in this development. And I say that the legislature of Parliament of the Republic of Ghana is equally open to negotiations and helping to ensure that the executive of Ghana's government, who is who has the mandate to ensure that there is adequate usage and proper judicious usage and development of the industry is effected. I thank you very much for the opportunity to share my thoughts. Like I said, I'll be standing by and we're here to continue with you.
Thank you very much, Honorable Acheampong, for bringing us up to speed. And we take away, obviously, the fact that you've really indeed stressed the importance of the country having proper pharmacovigilance in place, and how that can really be a change, a game changer. Let me, without any waste of time, introduce our third speaker, Senator Héctor Yépez Martínez, Assemblyman, National Assembly of Ecuador, Guayas Province, President, Commission of Autonomous Governments, Decentralization, Competence, and Territorial Development. Honorable Member, you have 15 minutes.
Thank you very much. Good afternoon there. Here we are still in the morning. First, I would like to apologize for any mistake in my English. And I want to begin thanking you all for this invitation, for this opportunity to share our experience and our problems, our challenges in Ecuador. Ecuador is a small but very beautiful and diverse country in the middle of the world in South America. I am a legislator since 2017 in the National Assembly, which is the name of our parliament. I have presided in the first 2 years of my term the Committee of Citizen Participation, and right now I am the chairman of the Committee of Local Governments in our parliament. In this committee, we have worked on a new law called the Act Against Drug Consumption and Micro Trafficking, which I would like to explain to you. We passed this bill on August this year with a very big support in our Congress. Practically 90% of the votes were in favor of this legislation. I would like to start first putting in context what is the problem that we are facing in Ecuador regarding drugs, and I would like to share with you some statistics from SICAT, from the Inter-American Drug Abuse Control Commission of the Organization of American States, that issued a report in 2019. According to that report, marijuana consumption has tripled and cocaine consumption has doubled in universities in Ecuador between 2009 and 2016. That is the highest variation of consumption in the Andean region for marijuana, and with Colombia the highest for cocaine. Regarding ecstasies, the report says that higher levels, and I quote, higher levels of direct offer of ecstasies in the last reported year happen in those countries where there is a higher consumption rate. The higher direct offer of ecstasies is reported by students of Colombia with 7.4%, followed by Uruguay with 4.1% and Ecuador with 2.8%. SICAT in this report ties, therefore, high levels of direct offer of the drug with high consumption, according to its wide regional research. We are also #1, unfortunately, in consumption of cocaine base, which is called in Spanish pasta base de cocaína, or in some countries they call it Paco. In universities, we are #1 in the consumption rate of cocaine base, and #2 in high school consumption, being the only Andean country with a significant rise with respect to this drug between 2009 and 2016. We're also #1 in crack consumption, and what does not appear in this report is that we have a problem, especially in the province that I represent, which is the province of Guayas, where the largest population of our country lives. A new drug called Ache, H in English, which is an inhalable mixture that includes heroin. There are several compounds. Everything is in research right now. Unfortunately, one of the problems we have in Ecuador is that we don't have updated research on this issue, but we have a terrible problem with consumption of Ache in the streets, especially in the city of Guayaquil and rural areas. Now, what has the state done so far regarding to this problem? Unfortunately, very little. In this administration, the National Secretary of Drug Prevention was closed by the present government. There has been no substitute entity to replace the role of coordinating a national public policy against drugs. There is no specific budget for drug prevention in the national budget of our state. We have no updated statistics since 2016. And the last report that we have in Ecuador, which is from 2016, already states that even if we have different dynamics of drug consumption in our country, depending on the kind of substance and the places where the drug is sold, we have a general problem of consumption, sale, offering, and easy access of illicit substances in education institutions and its whereabouts. Now, what have we tried to do in Congress related to this problem? First, I would like to clarify that I am not an expert, a professional expert on drugs. So when I had to preside the Committee of Local Governments where we passed this new act, the first thing that we agreed on doing is to stop proposing what, as legislators, as politicians, we would think is better, and first listen to the experts, especially the experts in field work, and to have a citizen participation process respecting, listening to the local diversity of our country. That is why we worked in this piece of legislation with people like Diego Riofrio, who is the director of the prevention office in the city of Quito, appointed by the mayor until recently, and who now leads the Instituto Prevent, and special social organization that works in advocacy and research in our country. We work with people like Mr. Bernardo Abad, who presides the Security Committee of the City Council of Quito, which is the capital of our country. We work with Dr. Julieta Sañay, who is an expert in the Neuroscience Institute of Guayaquil, the city I live in, and who now leads the program called A Future Without Drugs, which is a city program against drug consumption and that provides treatment for people who have drug abuse problems. We also worked in Cuenca, which is the third largest city in Ecuador, with people like Gustavo Valencia, who directs the treatment center 12 Pasos, 12 steps. So we made an effort to have a locally diverse number of people who could advise from the field work in the construction of this legislation. And now, what did we finally approve? First, I think we should recognize the limits of legislation. I know that people in politics like to overestimate the power of a law, of a policy, and we must recognize that law itself cannot solve the problem of drug use or drug abuse or of drug trafficking. We need a system to fight against drug abuse and drug trafficking. And the law must be seen as an important part in this system. And that is why we must have a dialogue with other people, other actors in the system for this to work. So, having first acknowledged the limits of legislation, it is not enough to put drug trafficking in the criminal code and then to think that everything will be solved. No, we need to work with the people in government, in the national central government, in local governments, with the civil society, with the experts in treatment, with students, education system, etc. Now, we also had to overcome a problem we have in Ecuadorian parliament and everywhere in the world. That is the high polarization, political polarization we have on this subject. For example, there is a big debate in Ecuador regarding the legalization or not of certain drugs, the punitive laws regarding drugs. What we did in this act is to make an agreement. Let us fight another day on these issues and let us focus on what we actually agree right now. And I think everyone, at least in Ecuador, and I think this is a worldwide reality, everyone agrees in the importance of prevention, of treatment, and of regulation in public spaces. Let us focus on prevention. We need to work with the families. And the national survey of Ecuador of 2016 already told us that when parents know where their kids are, there is 4 times less probability of drug consumption in that home. When parents and kids eat together every day, there is half the probability of drug consumption in that home. Also, when parents know the names of their friends of our children, half the probability. Or where are the children or the kids going in the weekend, where they are after high school, there is less than half the probability of drug consumption. So we need to work in prevention with the families. We also need to work in public spaces. The same report of 2016 revealed that the reality of consumption in Ecuador is collective, especially when we talk about drug use in young people who don't have their own money. The drug use is being held in groups, in collective spaces. So we need to work in the education system and in public spaces. With that in mind, what did we approve in this act that was passed in August this year? First, to have a local approach. The problem of Guayaquil with the H drug, which is very harmful, is not the same as in Morona, Santiago, a city in the Amazon region where we have the highest rate of marijuana consumption. So we need different approaches and we need to empower local governments, that is the city government, province government, and what we call in Ecuador, juntas parroquiales, which is a government of small rural communities, to have a specific approach depending on their specific reality. We created a participation of these local governments in the National Committee for Interinstitutional Approach on Public Policy for Drugs. So they have a say in the decision-making process. And we also included the voice of students in this National Committee. Regarding education, we approved to include prevention as a subject and as a general focus in the curriculum of all education institutions, private and public, since primary school until university. We also passed in this bill incentives for research and investigation in universities, since we have very few people who are trained in drug prevention in our country. In third place, we approved an incentive to strengthen family bonds, to work with the families, so that all treatment must, if possible, of course, involve the family, involve close relatives, people that live together with that person that has a drug abuse problem, because when we have a drug problem in a house, in a home, that does not only affect the person that is consuming the drug, but also his or her spouse, his or her children, or his or her parents. We created also a national fund for drug use prevention. With this fund, all assets seized for drug trafficking crimes must be used for prevention and treatment. And also, we have more than 300 buildings, houses, real estate in general, that is right now administered by the state and is having no practical use. So in this legislation, we approved that such public assets, the real estate of the government, must be used whenever possible for treatment and prevention. And finally, we approved that there is a more strict regulation on public spaces. As I told you before, and as the government reported in 2016, the last national report, consumption in Ecuador, especially among young people, is a collective phenomenon. That is why we need to stop, limit as far as possible, as much as possible, the consumption in public spaces. We have given this authority to local governments to pass city council legislation.
A few seconds left.
Okay, thank you. We passed legislation to authorize local governments to issue city council's regulation to prohibit the public use of drugs in common spaces in the cities, but without any criminalization. What we want is that local governments establish consequences such as fines, community service, to dissuade the drug consumption, but without sending to jail any consumer, because obviously we think that is not a solution. In the law, we stated specifically that we forbid any criminalization of consumption. With this, I finish my exposition. Now we need to monitor the execution of this recent legislation. We are in the middle of a world crisis, and it has hit very hard also in Ecuador, the COVID crisis, but we need to monitor the execution of this new act in order to help the families and improve people's lives. Thank you very much for your time and for the opportunity to share our recent experience in Ecuador.
Thank you very much, Senator Martínez. Let me take this opportunity to thank Senator Hunter, Honorable Acheampong, as well as Senator Martínez. Thank you very much for this amazing session. Just a few remarks. Well, South Africa, we work in progress. So the issue around the discussion we are having, substance abuse sits at the Department of Social Development, and that was a decision where we needed to decriminalize the issues around substance use, increase issues around prevention, but at the same time, advance free access to treatment for South Africans. And the treatment rehabilitation centers are actually the core responsibility of the Department of Social Development. We've just updated, of course, our drug master plan, which is a 5-year document. And why is really new that I think would be takeaways for our audiences today from South Africa. Issues of drugs is work in progress. And we cannot say we've made a lot of progress. We reconstituting our Central Drug Authority, which is the coordinating body that is based in the department. We currently Parliament is appointing new members. What is important for us as South Africans, it's the issue of the principle of self-representation, elevating the voice of drug users. And we've launched the South African Network of Drug Users to make sure that no legislation that will go through Parliament, any program that will be finalized, implemented without the voice of people who use drugs, as well as peer education, because it's important that even though I use drugs, it does not necessarily mean I've lost my inherent human rights as well as dignity. And I think what we've also done is strengthen the coordination, which I've heard honorable members talk about. It's very important that as you develop human rights, people-centered programs, you also strengthen your coordination, which is what we've managed to do from the local action drug committees, but also train our social service professionals. And I think one of our supporting partners, of course, Senator Hunter spoke about that, where we're making sure our professionals actually understand the issue around addiction and be able to deal with that. We now rolling out harm reduction centers. We've launched 3 already, where we are able to provide your needle exchange programs so that we can deal with issues around HIV, get to zero, as well as hepatitis C, so any blood-borne diseases. So South Africans who are intravenous drug users are actually receiving the issues around the exchange needles. But we're also starting a campaign on price reduction, which I think honorable members connected today, that remains a very important element of parliaments and senates and congresses. Let's work together to bring the price of substitution opiates down so that we can actually make it available to those that need it most. So I think this session is to get us there. Let's try and bring the price of essential medicine like methadone and any other that can assist us down. Let's also increase research and training. But thank you very much, Senator Martínez, for reminding us that the family remains the cornerstone of the fight against drugs. If we get it right in the family, all of our other programs will be very successful. Let me take this opportunity and thank you very much. I will be here, stick around so I can hear all of you, but let me hand over to Coceka Nogoduka from the South African National AIDS Council to deal with the Q&A, and she will hand over to Joanna, and I will meet you later as we do the closing session. Thank you for your indulgence, and good afternoon. Let's keep making a difference.
Thank you very much, DM. Good afternoon, colleagues that are participating in the webinar. I'm going to be working with the legislators that just presented, just to take a few questions that came from the participants. So our first question goes to Senator Hunter. Senator Hunter, the question is, Could you give some examples of how practitioners on the ground can inform and support advocates and legislation creators to ensure they are using evidence to develop their policies?
Yes, thank you very much. That's a really good question. So I've been in the field since 1981, and what I've learned over the years is that you got to be patient, very patient, and have lots of persistence, meaning don't give up, because you're not going to change the world overnight. You know, when we're talking about addiction and prevention, we have to work on changing people's minds and attitudes. And so therefore, you also need resources. You need support from the professional people as well as grassroots people, because you know, I was once a community organizer myself, and my strength came from not only my knowledge, but from the people who helped make me who I am today. And you must have lots of commitment. You know, this is not easy work. And so if you have patience and persistence, you have the resources that are needed, as well as commitment, then that's the majority of everything else that you need. And so, because when we're talking about reducing substance use, implementing prevention programs and intervention programs, you know, you got to have all of those essential qualities in order to make things work. Thank you very much.
Thank you very much, Senator, for that response. My next question is going to go to Honorable Acheampong. How can other African countries connect with and learn from the successes in Ghana to have positive impact upon their national policies? Honorable, I think you are on mute. If you could please unmute your mic.
So, sharing experiences of Ghana with our neighboring, our neighbors in the region, is the question, is it?
Yes, yes, Honorable.
Thank you very much. Because most of African countries are sovereign states and independent states, the laws that they enact will certainly have to flow out of the individual constitutions. I will also want to state that that is on the legislation side. And some of our states are federal states, and we in Ghana is a unitary state. So this is the challenge in the legality side. However, once we are all signed onto the African Charter and African Union Action Plan and the United Nations conventions, what the convention seeks to do is what we in Ghana have so far done. And so, like I said in my presentation, we are open to share with how far we have come. I know some East African countries have done well with their law and regulation in setting up an authority. We in Ghana, like I said, though we have enacted this beautiful legislation, the Parliament of Ghana is available. We have the records. You come to the Narcotics Control Commission. We have the Research Department. We have the Education Division, and we have the Commission also relating with other neighboring countries. We are ever ready to share our experiences, how we've been able to move on from just being a country which was centered on drug prohibition and encouraging our faith-based institutions to appreciate, because more often than not, it is the faith-based institutions that fought us in enhancing human-centered policies, like ensuring that we cultivated cannabis for medicinal use and for industrial use, because substance use disorders behavior has always been a challenge in our societies. And so social engineering was one of the difficulties. And aside, you had some professionals, but we were able to pull together a coalition, this via support of civil society organizations like ITTC and the lot. We put together a working group of professionals from the medical field, from the psychology sector, from us in legislature, and some very good lawyers for us to have an advocacy group and interrelate with various institutions for them to appreciate the need to enhance the legislation. So when this legislation is through now, we're engaging with the farmers who are already cultivating hard cannabis, and we're going to encourage them via the regulation, which is yet to be enacted by Parliament, to give the real architecture in the management of the farmers and the pharmaceuticals. So it is still a developing exercise. But by and large, because Ghana is part of African Union, our law is there, our personnel are ready, available to share in our experiences with any of our African sister countries. My experience in Parliament has been a 12-year experience in Parliament on this committee. And so, like I said, I'm the current chairperson, and we have enough knowledge to share, and the experiences are very useful for the African continent, because I know experiences from Uganda and experiences from Kenya, and they are good. Malawi recently, I saw their legislation, and I got very much encouraged. And that is what I would always, anybody listening to me on this platform, I will add that we should peruse our sister arrangements based on our national constitutions and the arrangements in the rule of law, so that we are able to promote legislation that the conventions that we've all signed on to at the United Nations and then African Union, we are able to domesticate them effectively. And by so, it is all through consultation with stakeholders, and then we will be able to make a very useful exercise with what we have done so far. I hope I met some expectation in the question, though. I don't expect to answer it 100% for you.
Thank you very much, Honorable. You've answered our question. I've got my next question that goes to Senator Martínez. Could you please give us an example of how national governments can work with local governments to engage them in policy change?
Thank you for the question. I think that's a complex and very broad question, but I think that the main thing, at least in our experience, that central government should do respect to local governments is to listen to their reality, and to, instead of, let me put it this way, instead of trying to instruct what to do to local governments, what we need is central government supporting the work of local governments, obviously within a national policy with the focus on health perspective, but helping the local government to execute. Because when we talk, for example, about prevention, working with the families, working with the local community, working with local schools, usually the local government will have a better understanding, a better access, more credibility regarding the local community actors, institutions than the central government. For example, in Guayaquil, in my city, there is now a new city program against drugs. It offers treatment, counseling. What we need from the central government is support, funding for that program. Instead of starting a political competition that sometimes happens. We need to put the problem of drugs beyond politics, and we need the central government to help with funding, which is what local governments in Ecuador, and I think this is a worldwide reality. What we need most is funding for local governments to address the problem with prevention, community-based prevention, and with treatment near the people. That's what we need. To put an example, I hope I have answered the question.
Thank you very much, Senator. You've answered the question. The last question that I have goes to the Deputy Minister of Social Development, Honorable Bogopane-Zulu from South Africa. Deputy Minister, you've been leading advocacy work around policy change on drugs and harm reduction. The question is, what do you see as role of civil society in advocating and be a loud voice that supports the work that you've been doing as a legislator around harm reduction? Thanks.
The good thing about us as social development is that we're also the regulator of non-governmental organizations, but we're also the funder of the non-government organizations from a financial perspective. So what is good is that civil society organizations are registered and funded by government, even though they are non-governmental. So it gives us a lot of opportunity, because a lot of our programs, especially community-based programs, we fund non-governmental organizations to implement those statutory services on behalf of social development. So what is important for us from a legislative perspective is that as countries, we need to acknowledge partnership and the power of partnership, but also we need to identify the role civil society can play in making prevention a reality. Because at the moment, as governments, we overwhelmed by the rehabilitation services, access to harm reduction. But if we partner with civil society, they bring access and universalization to the services. So I think that is what we need to take home. Is the takeaways is partnership, 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 and partnership with the different sectors recognized by ordinary people who are likely to be utilizing, misusing, and using drugs.
Thank you very much, DM, for your response. I would like to thank my legislators across the globe, different continents you are representing. But I think for me, underlying all your presentations, your comments, and your response to the answers that you provided here today, I think for me what came out is your commitment in serving the different populations that have elected you, the diversity of the populations, and also taking interest in supporting the harm reduction programs and interventions and all the impact that it has into our communities. So I would like to thank you very much for the hard work that you do in your different countries and this opportunity for us all to learn from you and the work that you are doing. I'm going to hand over this session to Joanna, the Chief Executive Officer, to take this session forward. Thank you very much.
Thank you very much, and thank you to the whole panel. That was really an excellent session and very enlightening, I think, for all of us as participants. So now we're moving on to the second part of today's plenary session, and we're going to really now look at the role of the traditional health practitioner and leader in drug demand reduction. Now, unfortunately, we were expecting to have the moderation skills and fantastic experience of Dr. Goodman Sibeko, but unfortunately he has been unable to join us, and we will miss you, Dr. Goodman, but I'll be now moderating this session. We are going to have a series of presentations to give us really the picture of the current involvement and importance of traditional health practitioners and leaders in the healthcare sector, as well as the activities they're undertaking and the role of successful collaborations and partnerships. So the first person we're going to hear from is Mr. Vukani Khoza, and he is the Director of Traditional Medicine at the KwaZulu-Natal within the Department of Health from South Africa. So we'll now let that presentation speak for itself. Thank you.
Good afternoon. My name is Vukani and live in Khoza. I work for Department of Health in KwaZulu-Natal, heading the section on traditional medicine, responsible for the institutionalization of the traditional medicine into the healthcare system, district health system via primary health care. In the Republic of South Africa, we recognize the Declaration of Alam-Ata, which recognized the role of the traditional medicine in achieving the goal for all. We understand that our patients often move freely between the two systems, which is allopathic and traditional medicine. In Africa as a whole, about 80% of the population depends on traditional medicine for primary healthcare needs. Initiative to actually institutionalize African traditional medicine date back to the 1994 democratic election. Prior to that, the African traditional medicine was not even on the agenda of the department. Legislative framework that we envisage in South Africa is that the practice of medicine is actually in line with the following prescripts. Number one is Section 27 of the Constitution, which states that everyone has a right to health care. It does not specify which type of health care, which means it includes African traditional health care. And then we've got National Health Act, and then the Traditional Health Practitioners Act number 22 of 2007, which regulates the training, registration, and categorization of the traditional health practitioners. Presently, we estimate or we approximate that about 3,581 practitioners are practicing in KwaZulu-Natal, and approximately about 300,000 in the entire country. In South Africa, the Act recognizes 4 categories of traditional health practitioners: Inyanga, or herbalist, diviner, traditional birth attendant, and traditional surgeon. Currently in South Africa, we don't have registered. TSPs are not yet registered with the council. The department is in the process of developing a formal registration system for all the traditional health practitioners. Province do have database for all the practicing practitioners. However, this database is just an approximation because not all of them, of the traditional health practitioners, are actually appearing on the database. In South Africa, traditional health practitioners are regarded as essential healthcare providers. Our former icon and state president, Nelson Mandela, had this to say in terms of traditional medicine. I quote, "Traditional health practitioners often have greater accessibility and acceptability than the modern healthcare sector and should be used as a vehicle for health promotion," unquote. We as a country, we do subscribe to the above statement, which actually recognizes the role of the traditional health practitioners in the delivery of health promotion services to our communities. Currently, in South Africa, traditional healthcare practitioners are involved in following aspects. Health teams, they do participate in traditional health practitioners' rituals and give health talks during their function. We train, they are used for triaging and referral of patients to appropriate level of care. For an example, we recently we're recovering, or we're still in the process of undergoing through the pandemic of COVID-19, where we train traditional health practitioners to triage and refer any patients they suspect to be presenting with symptoms related to COVID-19. They are used for public education in order to contribute towards reduction and prevention of disease. They assist patients, with patients that are actually defaulting their treatment, more especially with regard to a chronic medicine treatment. They contribute towards dissemination of public health awareness messages, educate community on importance of simple basic hygiene and nutrition. They provide counseling to patients. Some of our traditional health practitioners are even trained on doing rapid testing in terms of TB and in terms of HIV/AIDS. Work with team from the Department of Health in community outreach and health promotion programs. And they participate in our health programs. Traditional health practitioners, they receive training on conditions and how to refer and where to refer. They are utilized in campaigns and also to mobilize community for special programs like voluntary male medical circumcision. In South Africa, we have many organizations and associations to which some or most of our traditional practitioners are affiliated or associated with. In order for the department to actually communicate properly with traditional health practitioners and strengthen the relationship between the two, we have formulated or constructed what we call communication structure in order to be able to communicate with our traditional health practitioners. These communication structures or committees are present at all levels, starting from sub-district, provincial, and national. We call them communication structures. They are meant for actually strengthening the relationship between the government and traditional health practitioners. These structures or committees, they meet on a quarterly basis at the appropriate level to discuss the issues relating to institutionalization and relationship between the department and the traditional health practitioners, and also raise some issues and challenges in order to strengthen the referral and the relationship between the department and the healers. What then do we envisage in terms of drug reduction program to be the role of the traditional health practitioners? Firstly, we need to empower them in terms of the available programs, in terms of what are the signs and symptoms. And then they must be aware where to refer in terms of facilities. And they need to participate in the program event. If we've got a drug reduction day, they must be part of that particular event. They can assist by displaying health posters relating to the program in their consulting rooms, because communities will be able to access those. Spread messages to their clients and communities about the utilization and the abuse of drugs within the community, including their dangers. THPs, then they need to be provided with IEC material to distribute. That is information, education, and communication material to distribute to the communities and to their clients. They must train conventional health practitioners on relevant cultural aspect of the program. Please. What do we require then for the program to be successful, or for successful collaboration. First, one needs to recognize and appreciate traditional health practitioners, that they exist within the community and they are practicing. The moment we don't recognize and accept their presence and their practicing, that's when problem actually start. We need to consult. There must be a consultation with them and their leadership. That's very important. The moment you don't consult with them, and the moment you don't consult with their leadership, it's when you encounter problem and rejection and being unable to be able to actually work with the traditional health practitioners. We need to involve them in all activities regarding drug reduction program, starting from the planning, implementation, and evaluation stage. Also, when we deal with traditional health practitioners, you need to be culturally sensitive. And when dealing with them, you use simple language and be sensitive towards their literacy level. Most of our traditional health practitioners, they've got very low literacy level or none at all. They can't read, they can't write, and so they need to be assisted in that regard. And also, what is important is to give them feedback. In case they refer patients for certain treatment or certain rehabilitation, one has got to give them feedback that, thank you very much, you received so and so, and this is where we are with him or her. We request maybe further assistance in managing that particular problem. Thank you.
Thank you very much. So we're now moving on to hearing from Uganda, where we have Dr. Grace Nambatya, who's the Director of Natural Chemotherapeutic Department within the Ministry of Health in Uganda.
Dr. Grace Nambatya Cheyune, Director of Research, Natural Chemotherapeutic Research Institute under Ministry of Health. I'm a PhD in medicinal chemistry. And I also hold a postgraduate diploma in education. I'm a board member of our regulatory agency, National Drug Authority. I've been a board member for 15 years now down the line, and currently particularly on pharmacovigilance committee looking at adverse drug reactions. The topic is exciting, and it's just confirming the critical need of scientific validation in the area of natural products, because lack of that validation has always held behind all issues regarding abuse, because if you don't have evidence, then you can't convince people. Yeah, so it's exciting. It is, and our regulator, the National Drug Authority, has been at the forefront of really sensitizing the public, though focusing mostly on adolescents in schools, because given that Uganda is one country with the youth, the percentage of youth is so high, the focus was on that, but we are challenged by regulations in that area that are not really very strong in terms of penalty, you know? Yes, so, and the issue of truck drivers, as a landlocked country, we have these truck drivers. I think they use lots of such things to stand up to the pressures of long journeys. And so Uganda has been trying really through our regulator, but of course the regulator is under Ministry of Health. Yeah, so yeah, there are efforts, and in terms of also recognizing national days that really talk about what we should do to mitigate, giving out materials with messages to remind us, you know, substance abuse, drugs, alcohol, cigarettes. The drug issue, yeah, is quite strong when you talk about cut and cut since it's not even captured under the regulation. So it makes it a challenge, really. Yeah. Actually, at the moment, they're mainly organized in associations. If you hear that Uganda has 100 districts, you will know it has 100 associations, small and big. And since the Act of Parliament now is on, actually, the main issue we have to address, we should ensure that these small associations are supported to come out into one big national association, like it is in other countries. Because if there is that national association, actually like it is in South Africa, these people would have governance structures and they would have a voice. Because when you look at the Act, it over empowers the minister. She's the implementer of almost everything, but she's medical, you know. And today you may have a minister who may not even want probably to hear the word tradition, you know. So that means on her part, it may not be a priority. Yeah. So the only chance we have in Uganda is natural chemotherapeutics, the one I'm heading. A part of our mandate is to support the ministry to help out in issues of traditional medicine until a time when they have their own council, which is coming soon. This traditional medicine setting through us and the Ministry of Health, it partners a bit with Ministry of Culture. There is local government, and under there, in their laws, they're empowered to come up with groups for business purposes. So these have been groups for business purposes. Yeah, we can leverage on them and start from there, because some are well organized. You know, it's a matter of knowing how well to do it. Yeah. Currently, they function separately because there have been no frameworks to inform this modern health worker of their legalities. Though we have a public-private partnership health policy, which was enacted in 2012, having a whole chapter on recognizing traditional herbal practitioners as public, as private healthcare providers. But of course, this other one I'm talking about that was recently assented to had to be in place for the other one to be active. So based on that one in 2012, there had been, thinking or plans that these practitioners, they would be leveraged on to pass on messages to their clients, health messages, use of a condom, referrals if like HIV patients, not to completely keep patients to themselves. But because there was a lack of another law, this was never implemented. But at the moment under COVID, of recent, there has been a launch of a communication engagement strategy. This was as a result of the increasing community infections and COVID, where the ministry felt that people need to be empowered, that now you have to take health in your hands. And that strategy put in place engaging village health teams. These village health teams, part of them are traditional healers. I see it as a channel that can be leveraged to pass on these messages, because the VHT system here is very, very well laid out. Yeah. So this VHT keep pass on every village who will be passing on messages like prevention of COVID. I'm seeing it as a way where you can empower that one also to pass on other messages, probably linked to drug abuse, you know, because that person is going to be of a particular level of education where they are able, and they'll be supervised by district health teams. That is as new as 2 weeks under COVID, but I think it's going to leverage other issues. Actually, capacity building in terms of giving information, you know, if you show the pros and the cons, and also mentoring them into varieties to grow, because there are varieties that have lower bad side, you know, like when you talk about cannabis, you can have a one with a very low THC. You just teach them. And when you talk about herbalists, we have a tendency of thinking that they are not educated. Here, some have PhDs. Yeah, some have done chemistry. It's like an area, if you want to make money, you know, the demand, people falling sick and those who don't want to fall sick, you can serve either community. So we've not been having training institutions, but with this law in place now, we're going to have training, and with training, people get to learn, and once you give information, once you show them the payoff, they'll quickly pick it up. So the role of traditional health practitioners is going to greatly be in helping out in capacity building, in telling the people, even not only about the herbals, but the diseases themselves. There are many other natural products published on already, a lot of chemistry done, and what was missing was, where is the patient? Yeah, you look at safety and then you do. So we have here herbalists who submitted a number of samples for validation, and part of them are those drugs we are talking about. The Ministry of Health should leverage on this act to sort of formalize as if it's implementing, yeah, because there is need for the traditional health practitioners to feel that they are accepted, because lack of this act has been indicating as if nobody cares. So a formalization process to accept the traditional health practitioners is critical, but I believe it will be done because we have a program under COVID to expedite most of such things. And once that is formalized, then they can be tasked to start off with these messages, carrying messages, because we're having a challenge of messages not reaching to the deep corners of the country. And these traditional practitioners are amongst the population. If you give them trust for them, they will be so happy, and then tasked to carry on these messages, simple messages. We can first start with the current challenge, COVID, and then we bring in those the drugs, you know, the drugs demanded, because you want to start with the most current, and then you make your package. Yeah, thank you too for giving me this opportunity, because I believe what we've discussed is not only needed in Uganda, but Africa at large and the globe at large, because it involves business as well. Thank you.
Thank you very much. We're now moving to Kenya, where we're going to hear from Professor Jennifer Orwa at the Center for Traditional Medicine and Drugs Research, based there.
Good morning. Thank you very much for inviting me to present in the Traditional Health Practitioners Forum. I am Jennifer Orwa. I work at the Kenya Medical Research Institute. I carry out research at the Center for Traditional Medicine and Drugs Research. And I also have the responsibility to guide the resource development and knowledge management department in the institute. So I will be able to talk about traditional medicine because I've had the experience working with the traditional health practitioners as well as on the medicinal plants. So today we are going to discuss mainly the involvement of traditional health practitioners in healthcare in Kenya, the current involvement. We'll also touch on the relationship of the traditional health practitioners with the formal sector, the role we envisage these traditional health practitioners to help us in drug demand reduction, and what would be required to facilitate a successful collaboration between the THPs and the conventional practitioners to tackle the DDR challenges. So on the current involvement of THPs in healthcare in Kenya, we do know that traditional medicine in Kenya is widespread, particularly in the rural areas. And this popularity of herbal medicine has been attributed to the wider cultural belief the community believes that, people are much closer to nature if they use traditional medicine. They also are able to access the traditional health practitioners, and there is the belief that these traditional health practitioners are able to provide treatment at an affordable rate. In fact, currently there is a resurgence of interest in traditional medicine, and many researchers are actually now focusing on medicinal plants for their projects and to try and find out if there are potential medication for healthcare. This has actually been attributed to the fact that using modern medicine have had very many challenges in treatment of some chronic diseases as well as other conditions. Also, the inability of the modern health facilities in meeting the health demands of the population is increasing, and only few are able to access the conventional medicine. Currently in Kenya, the regulatory structure actually involves the regulation of the traditional health practitioners and the products. And the traditional health practitioners are actually registered by the Department of Culture. And the products are registered and regulated by the Pharmacy and Poisons Board, which is a regulatory authority of the Ministry of Health of Kenya. So we have two sets of regulation. And what is the current relationship of traditional health practitioners in the formal health sector? Our government do acknowledge the usefulness of traditional medicine, and there have been many initiatives to develop policies, strategies to guide the mainstreaming of traditional health practitioners in the healthcare. But traditional medicine has not been effectively mainstreamed in the overall Kenyan primary healthcare sector. And we still have a lack of legal and policy guidelines. But who is responsible for the derailment of implementation of these initiatives of developing policy so that we can mainstream the overall THPs in the overall traditional, in the overall primary healthcare? I would say probably all of us are to blame, all the collaborators may be to blame, even starting with the traditional health practitioners. The traditional health practitioners have been having a challenge of getting together, forming their traditional health practitioners associations so that they can understand each other and come together to focus on how best they can be mainstreamed in the traditional health practitioners. The conventional health practitioners also are taking long to accept the traditional health practitioners. So mainstreaming and getting them work together have been a challenge. The scientist is actually responsible also to help us with the documentation and finding safety and the efficacy of these traditional health practitioners, because the conventional health practitioners would like to see evidence of these traditional medicines before they can accept to collaborate with them. So the scientist is also slow at doing this. And of course, if policymakers, they're the ones responsible for actually ensuring that this happens. So it looks like all the stakeholders in the traditional medicine space, we are all responsible for the slow intake and having this good relationship of THPs in the formal healthcare. And as I was said, there has been push for integration of traditional medicine into healthcare since a very long time. In Kenya, we tried engaging the traditional birth attendants in the mainstream healthcare, but this apparently did not go well with some other practitioners, and it did not continue. So we have a challenge there. The THPs currently in Kenya, we have them being registered to practice, and also they own clinics, but these here, they work in silos. They are not in the hospitals or any recognizable healthcare sector. The government actually some time back established the Center for Traditional Medicine and Drug Research at the Kenya Medical Research Institute, where I work. And this center was established to validate practices and the products through evaluating the safety, the efficacy, in an effort to encourage streamlining of traditional medicine in primary healthcare in Kenya. This is continuing, and it's really my prayer that we will eventually be able to integrate traditional health practitioners with enough research evidence. So how do we envisage the role of THPs in drug demand reduction? I want to approach this by making reference to the 1990 World Health Assembly resolution on reduction of demand for illicit drugs. The WHO resolution resolved that preventing the spread of drug abuse in individuals, families, communities, and counties would take a big role in reducing drug demand. So where would the traditional health practitioners come in and help collaborate with this activity? As I had said, traditional medicine is culturally accepted, and so the traditional health practitioners are really well placed and have an advantage to be able to communicate at the community level where they work and be able to sensitize the community on drug demand reduction methods. They have the advantage for this. How about the resolution on developing effective approaches to treatment of drug dependence and associated diseases? THPs could come in to help with developing effective approaches, because we know that herbs exist for the management of several diseases, including even managing the reduction of drug demand. The only challenge probably here would be that it is important to establish scientific evidence, but it is well appreciated and acknowledged that we do have herbs to control this. Then the third WHA resolution was collaborating in controlling the supply of illicit psychoactive substances. So I envisage the traditional health practitioners being able to engage the communities in various fora. And because they are accepted, it is, I think, easy to have them talk to the community. The community will listen to them, so they just have to engage them in various fora in trying to tell them, the importance of controlling the illicit substances. So what would be required to facilitate a successful collaboration in tackling drug demand reduction? In my opinion, I believe that the good laws in Kenya, the policies, the robust regulations, and the preservation of intellectual property rights will help shape the traditional practice in Kenya. Acknowledging IPR would actually enable indigenous knowledge to share freely their knowledge. We know that previously indigenous knowledge practitioners have held their knowledge and handed it down from generation to generation and in secrecy. But if we allow them to actually protect this IPR, they will be able to share with us freely. And this, I think, would be able to facilitate collaboration. And implementation of guidelines for safety and efficacy evaluation in efforts to encourage streamlining of traditional medicine in primary healthcare in Kenya would be another point to be able to help us facilitate the successful collaboration. And of course, there is need to involve the traditional health practitioners associations, like in Kenya, where they are guided by the Department of Culture. This department has been able to form a National Traditional Health Practitioners Association. And this is able to make them come together and discuss in partnership. So I think these three would be able to facilitate collaboration. And I believe if we have all these in place, we can be able to successfully get the traditional health practitioners and their indigenous knowledge, help us tackle the drug demand reduction. Thank you very much for listening.
Thank you very much. Again, that was excellent to have that last perspective. We're now moving on to Dr. Pelmos Mashabela, who is the Deputy Chairperson from South Africa Central Drug Authority, based in South Africa. Thank you.
Good morning, good afternoon, or good evening, delegates, depending on where in the world you are. My discussion today is really going to focus on the role of traditional leadership in the space that they can play within the DDR policy, but with a particular focus in South Africa. Now, just as a preamble, I thought it might just be helpful that I share with you, distinguished delegates, the landscape of South Africa as a country. It is made up of 9 provinces. I'm not going to bore you with the name of the provinces, but I must just sort of share with you that in terms of the number of people or that constitute rural or traditional communities, there's approximately 21 million of those. Those are the kind of population that are within the traditional leadership in the country. Now, just as in terms of the background, I just want to share with you that in South Africa, for example, traditional leadership is a sine qua non in rural areas. The leadership or the institution remains as a custodian of culture, customs, origin, and history. Now, it is recognized through the Constitution that this institution, its status and roles are legislated. So it is part of the democratic dispensation of the country. 70% of South Africa's poor people, they live in the rural areas. And the authorities of the traditional leadership retain more influence over this population than it is the case in the urban areas. The chieftainship was and still is a common form of authority, especially within the, or exclusively within the Black communities. We do have the mining towns that are, specifically linked to the rural areas where migrant workers live, and these, of course, form part of your key population. Women form the majority of the rural population, and the female-headed households are particularly disadvantaged in those communities as well. In the main, the system is patriarchal, yet there are few exceptions where it is matriarchal. The municipalities that we do have in the country also form part of the rural communities as they would with city communities. For instance, just to share a little bit of, again, the landscape of the country, we do have 3 capital cities, and this is quite interesting. For example, Pretoria is considered an executive capital, whilst Bloemfontein is the judicial capital, and Cape Town is the legislative capital in the country. Now, South Africa has about 8 metropolitan municipalities. These are the big metros, like your large cities. However, it is also made up of the 44 district municipalities and the 205 local municipalities. Maybe the question is, where is this going? This is important in the context of what you call the local drug action committees, which is part of the role that is being played by the CDA, for which this conversation is going to be largely based on. Now, in terms of the traditional leadership, again, there's about 8,241 legally recognized traditional leaders in South Africa. The breakdown of is as follows. There's 9 kings, 2 queens, 2 principal traditional leaders, and just about 7,000 head women or head men. Now, with regard to the traditional council, currently there's about traditional councils that are existing across the 7 provinces. And the breakdown, maybe just in terms of the slide, I just want to go to the slide that deals with the breakdown so you can see clearly there. Initially, I said there's about 9 provinces. The only province in the country that does not have traditional leadership at the moment is the Western Cape. So the other 8 do have traditional leadership, which is explained at the beginning of the table. Now, what is the objectives of the House of Traditional Leadership? As legislated, the objectives, 1 is to promote the role of traditional leadership within a democratic constitutional dispensation. 2 is to enhance unity and understanding among traditional communities and advise government, especially national government. They are not elected into office, they come through what is called lineage. Now, how does this then relate to the National Drug Master Plan? Traditional councils, which is what is a structure within the traditional leadership, have a role to play in the reduction of the demand for drugs and prevention interventions. The incorporation of the municipal master plans should integrate the issues from traditional leadership, and it should improve the coordination at the local level, as they rule over 70% of the rural communities. Now, we also see government through the Departments of Cooperative Governance and Traditional Affairs and the Department of Health, we think should initiate DDR programs in those communities as it is the case in the cities. Now, when you look at the key POPs, these key POPs are also prevalent in the rural communities. We talk about the people who inject drugs, female sex workers, men who have sex with men, and so on and so on. These are communities that are also prevalent in the rural communities, and we believe that they should be attended to as well. Now, what are the things that needs to be, what would be required to facilitate a successful collaboration? 1, we thought there should be closer working together between the CDA, the traditional health practitioners, and of course, traditional leadership. There has to be a working together. Advocacy on the substance use disorders within the rural communities has to be strengthened. We need to amend the Act, which rules on prevention and treatment for substance abuse, to include traditional leadership in the CDA structure explicitly. Another area that we thought could be important is that there should be more training and awareness raising on DDR interventions for traditional leadership. The provincial substance abuse forums and your local drug action committees should work together with traditional councils on the drug demand reduction. We believe that traditional leaders hold natural resources such as your land, your minerals in trust for traditional communities. Therefore, they have an opportunity to enter into partnership for development of their own communities. And there has to be more working together between the municipalities and the traditional council and your traditional health practitioners. Now, we also wanted to prefer certain number of policy recommendations that I believe could be assisting the process. 1 is that the Act, the Governance Framework Act, places an obligation on government to promote and protect the institution of traditional leadership. So this structure is legislatively protected. 2, we believe that traditional leaders should establish your local drug action committees where the authority of the municipality and the mayor is limited. We need to consider the ward-based local drug action committees to strengthen your drug demand reduction interventions, and we need to capacitate young people and rural women on the opportunities that exist within the DDR context. We need to promote partnership between municipalities and traditional councils through legislative measures, and we need traditional leaders to play a vital role in the development and financial sustainability of traditional and rural communities. Lastly, we believe that there has to be a prevalence survey on the epidemiology within the rural communities under the traditional leadership, which must be conducted, as data largely is based on the cities and the towns. Once more, I just want to thank you for the opportunity, and that then concludes my presentation. Thank you very much.
Thank you very much, an excellent local perspective. So we're moving on to our last presentation now from Mauritius, and that one is from Dr. Rajuta Gaikwad, who's the Ayurvedic physician at Mahatma Gandhi Ayurveda Hospital in Mauritius.
Yes, I am Dr. Rajuta Gaikwad and working in the Mauritius in one well-known Mahatma Gandhi Ayurveda hospital. And since last 7 years I am here, and in India I was practicing Ayurveda yoga 25 years, as well as I was visiting and conducting some workshops in European as well as Asian countries 10 to 12 years. So now I will turn to my topic, which is the traditional health practice and in Mauritius. Traditional health practice started in 1985 in Mauritius. And since our hospital, Mahatma Gandhi Ayurveda, is existed and giving service to substance abusers. The THP works in close collaboration with Ministry of Health and Quality of Life in Mauritius. We sent monthly reports to the ministry and keep records according to their suggestion also. This is my hospital building, and many are coming and visiting our hospital. So this is one slide, which is the Actresa, means Ayurvedic Center for Treatment of Rehabilitation of Substance Abusers. And next to there are two photos in which you see that we are moving, making march for no alcohol, no smoking, no drug, like these banners a lot of people are having in their hand, and the first banner is of our Human Service Trust. We make all these movements by many ways. This is the live radio show, and I am directly answering to the questions from public. Lot of people are asking me questions, how you do deal with the substance abuse people, what you do for that, do you home visit? Yeah, many questions they ask, and I give how we free of cost giving the treatment for the patients. This is the public speech. I am visiting social welfare center as well as women empowerment, and this is the public speech regarding the harm caused by the illicit substances, and thus try to reduce the demand of the drugs. I am explaining lifestyle and etc. and the problems creating in the health. This is that I am distributing the brochures in Ganga Talav here in Mauritius. In Mahashivratri, millions of people are visiting, so we make pendal, free food distribution, and I was there to give the information. And this is our brochure. This is the yoga class I am conducting. This is one activity for the people who are abused by the substance, they need some stress management techniques. One March, our Prime Minister was also participated, and one is the Munshiji, he is the director of this unit of substance abuse, and middle one I myself is. In this movement, we are getting help through lot of NGOs and social giving social help organizations also. Now about few words about the Ayurveda and Yoga. Ayurveda is a way of life as well as traditional therapy also. And Yoga is a way of life too, but later it recognized as a therapy. Oldest Indian 5,000 years traditionally time-tested health science. And the objective of Yoga as well as Ayurveda is to maintain the health of healthy and to pacify the elements of deceased. Ayurveda treatment is divided in two parts, and Panchakarma is the unique feature of Ayurveda to detoxify, to purify the body and mind. Here are few original Sanskrit words, terms. Oil massage and fomentation, Snehan Svedan are preparatory practices of Panchakarma, popular in worldwide. We choose 2-3 procedures out of 5 suitable for age, time, place, and season, and make it with monitoring closely. We use medicine in form of powder, infusion, decoction, buttermilk. Each karma has different route through which medicine is injected, absorbed, and toxins are thrown out of the body. For example, Vamana, third one, Vamana. Vamana means emesis. Patient drink decoction and vomit lot. Toxins are collected by oleation, fermentation in the stomach and thrown out through the mouth. Virechan is the toxins thrown out through purgation. Nasya, medicine is introduced by nasal way, nose. Basti, medicine is introduced by rectum. Large intestine absorb that medicine to detoxify the body. Raktamokshan is one special, but we are not using here. It is done by the leech, one like earthworm, small insect. And last one is not Panchakarma, but it is a stress management technique, single stream of warm oil over third eye, especially those complaining for the insomnia, restlessness, palpitation, in this way. We are using some herbs, Ayurvedic herbs, and some popular herbs I am mentioning here. First are the Sanskrit name and next is the Latin name. Brahmi, Ashwagandha, Guduchi, Jatamasi, Shankhapushpi, Bhrungaraj. Just I will talk about it. Brahmi is for insomnia, Ashwagandha is for stress, Guduchi is for immunity, Jatamasi, Shankhapushpi the same way acts on the brain and the pattern of thinking, as well as Bhrungaraj is also cooling, all those herbs and their preparations which are traditional one. For example, the names Saraswatarishta, Arogyavardhini Vati for liver, Manasyadikvatha to have the peace of mind. We use such a traditional described medicines and preparations. Ghee is the best Ayurvedic medicine which is used as a vehicle also. When we give powder, when we give some other medicine, we ask to mix the ghee in it. Ghee pacifies Tridosha. A good catalyst carries medicine qualities, properties of herb into the body. Brings clarity of mind, good for memory, intelligence, and wisdom. Sustain healthy microbes in the gut. You know the word sattvic, which is again popular word. Ghee is a sattvic one, increases good qualities of mind, brings positivity in the personality itself, purifies mind and intellects. Arts want to use in diet, in the cooking, medicines, of course in the panchakarma. Now I will turn to the panchakosha or yoga techniques. Yoga describes our existence according to this concept. This concept is that Annamaya Kosha, we existed grossly by this Annamaya Kosha. Anna means food, food sheath. Next, we have some energy which is moving and doing some activities, that is Pranamaya Kosha. We have mind and as well as the emotions. Emotion and intellect is the two gifts given by God to us, and with it we are interacting, and those are the special features of human being. Otherwise we are like the animal. And next is the Anandamaya Kosha, means our nature, blissful nature. So we ask patients to do asana to servicing maintenance of Annamaya Kosha, pranayam for Manomaya Kosha, some bhakti yoga, spiritual things for Manomaya Kosha, some philosophical things, satsangas for Vijnanamaya Kosha as well as Manomaya Kosha to balance their emotions, to balance their mind. And meditation. Meditation, it includes concentration, contemplation. The same way, japa, many techniques we are using for meditation, but the ideal meditation in recovery phase. Yoga Nidra is also the one of the technique which is very popular. It relaxes the physical body as well as the mental, emotional body. So by Yoga Nidra we use to strengthen the resolve, which is very essential for substance abuse people not to relapse their condition. And few yoga kriyas also. In this way, we treat our patients by giving talks as well as by giving some march, giving some brochures, and of course we visit, we give home visit, we ask to come, we counsel them. Counseling is the important part of the treatment, in which we give motivation, we give the determination to get rid of the drug, we support them, always we assure them that we are with you, even though there is relapse. It happens, we help them, we give the parental role as well as friendly role. We plan how to do it, we advise them by medicine, by lot of ways. We try to open them and we try to help them. So thank you. And in this way, with the help of government, with our information and with our dedication, with my institute, with my directors, I am trying to help such a substance abused people. Thank you.
Thank you very much. And thank you to all of our speakers there. I'd like to invite you all to now turn on your cameras and your microphones as we put some of the questions from our participants. Thank you very much. Now, first, I would like to go over to Dr. Jane Marie Ongolo, who has joined us from the African Union, to welcome your comments on the session. Sorry, Jane Marie, we can't hear you. maybe we will move on to the questions, and then I'll come back to you at the end for your comments from African Union. So first of all, if we have Mr. Khoza, are you here with us?
Yes.
Wonderful. So we had a question come in which said that a couple of the other presenters talked about health messages and how those sort of filter through to the ground. And one of our participants asked if South Africa has a centralized system for developing the health messages related to drug use demand reduction via this network of traditional leaders and health practitioners, and wondered what the challenges are of creating and then sharing the health messages.
To be frank with you, in South Africa, we don't have such a centralized system. For all the departments that are actually running the program, they'll have their own system of actually decentralizing and filtering the messages down to the ground. But for many years, we have not, the role of the traditional health practitioners has not been included in such a, in this program. It's a first of its kind that traditional health practitioners are involved in issues of drug abuse program.
Okay, thank you very much. It's a challenge, I think, for many countries and many networks of practitioners to develop those messages and spread them effectively. Yes. Now, moving on, we have a question for Professor Orwa, and to ask about training of this network with the particular issue of drug demand reduction, and if there's any experiences or sort of good practices that you can share on how to help this particular network access training or, you know, become very familiar with this particular subject.
Thank you very much. The networks, we have not managed to help them with training. Some of them have set up some training institutes, but this has not borne fruit. And what we are suggesting now is to try and you know, encourage the universities to introduce this at the, you know, the level of the medical school, so that we can have our conventional health practitioners appreciate the traditional health practitioners. And then training, as we had said, in my experience, traditional medicine is something which is not very easy to understand. I know in the pharmacy department we train pharmacognosy, but it's just on the use of medicinal plants so that we can extract them and develop modern medicines from them. But the traditional medicine, as it is practiced and as it has been practiced for very many years, it's not easy to set up a training school for traditional medicine. But yes, we can train them on how to best use the traditional medicine, how to protect, how to ensure that they can formulate them in formulations that are acceptable by the community. And you know, with the medicinal plants, unless you have an apprentice from the other traditional healers, it will not be easy, you know, to have a school where me as a pharmacist who have done a lot of pharmacognosy and know a lot of medicinal plants, go and try and train, because they may use them differently. The healer who has been gone through apprenticeship will understand how to prepare and what kind of mixtures to put in this product. Even if it is a toxic plant, they actually know by intuition, by, you know, seeing the other practitioners make these medicines. So formal training, in my opinion, it's a challenge. We can only train on medicinal plants and how we can successfully carry out R&D up to innovation and product development. Thank you.
That's very insightful. We now have a question which has come in for Dr. Gateward about how the practice that you described to us really has had to change during the period of COVID-19, and how effective it has been able to remain, and what the challenges have been of working during these conditions. Maybe our speaker had to leave us or is having some connection issues. We'll move on to the next question, which is for Dr. Mashabela. And one of our participants asked what the challenges are of linking the modern and traditional health practices when relating specifically to the prevention or treatment of substance use disorders.
Well, thank you. I think it's a great question. It is extremely difficult to really say how we're going to link it, but I think each state and each community will have their unique ways within which they relate and they interact with the traditional leadership as well. But for us, really, it has been a very phenomenal interaction between the democratic institution, which is regulated through the municipalities, and the rural communities, which is mainly also regulated by the traditional leadership, to see how they can work together. Because at the end of the day, when you look at the drug demand reduction, it wouldn't matter whether you're in the city or you're in the towns or you're in the rural communities. I think what then becomes an issue is what kind of drugs are being used in any of those communities. And on the basis of that, and I think the Deputy Minister also raised it, just to conclude, is that we are then investigating ways within which we are going to integrate the traditional leadership into the organizational structure of the Central Drug Authority, so that at the local level also they form part of the discussions around the issues of drugs. So basically that's how we are exploring, and we are working together with them in that direction. Thank you very much.
Thank you. I can see you now. Did you hear? Would you like me to repeat the question? No, we can't hear you very well, I'm afraid. Just let us check your settings. It looks like your microphone is muted. No, it's still not connecting. Well, I invite you to respond to the question via email, and we can pop it on the ISIP network so that our participants can go back and read about your response to that question. I'm sorry that you weren't able to answer it in person. Now, Dr. Ongolo, have we been able to connect you? It's because I've put you all on the spot this afternoon.
Joanna, Dr. Gateward is unmuted.
Dr. Gateward, can we hear you now? No, we can't. I think even before Diana, there was a problem with the connection. So, Jane Marie, we should be able to hear you to give African Union's perspective. Thank you for your patience, everybody. We will just give her a moment. Everybody's working very frantically in the background to try and get these technical issues resolved. We're not quite sure why we can't hear you, Jane Marie, because it does say that your microphone is connected. Could you just check which microphone you have selected? I think we're going to have to move on. I apologise, everybody. It would have been wonderful to have been able to have heard from African Union to make a comment upon this panel and the issue, but I think unfortunately we are experiencing technical difficulties that we can't resolve, and I don't want to leave you all sitting here waiting. So that really leaves it to me to thank the panel. It was very interesting to get the perspectives of the contrasts from the different countries, but also to recognise really the role of the traditional and the health leaders in this field. So we do appreciate you bringing that to this global audience. It has been very, very interesting, I think, to hear about it from that national perspective. So thank you very much to all of our speakers from both panels. Of course, we did also hear in the first part about the role of legislation, and we've had sort of two contrasting, very specific impacts which are essential in the jigsaw that we all sort of piece together to really be dealing with substance use disorders. Thank you very much to all of you who are listening, and thank you to the ISIP staff who are working very hard behind the scenes to bring this together. Thank you to our partner organisations who have helped us to devise such an excellent programme and introduced us to fantastic speakers. I would like to extend our sincere thanks to Honourable Hendrietta Bogopane-Zulu, the Deputy Minister who was our moderator for the first part of this session, and again extend our thanks and apologies really to Dr. Goodman Sibeko, who was unable to lead on this particular session where his expertise would have been wonderful. Just to let you know that the slides and the recordings of this session will be on the ISIP website as always, and we will hopefully put links to resources and anything that will be of use to you as listeners, as well as continuing some of this discussion and answering some of the questions in the network which is related just to this event. The next session is taking place next week on November the 10th at 2 o'clock South Africa time, and that will be our last session in this series, and it will give us the chance to review and reflect upon the series of plenaries, the many subjects that we have covered, and allow some of the questions that we haven't been able to cover to be addressed. Thank you again for listening. Thank you for all of the comments and questions that we've had in the box. We hope that it has been a beneficial session to you all, and we look forward to seeing you next week. Thank you very much.
Thank you, Dr. Mashabela. I'm glad to see you again.
Good to see you too, Prof.
Thank you. Bye.
Bye.
Bye, Dr. Jade.